Well, welcome everybody here. I have today a very special interview for all of us to watch. A very special guest, one of my absolute favorite gender affirming surgeons. Let me see if I can get this right because we just talked about this. Um, Steve, no, probably didn't get it right, but you're going to say your name yourself, Dr. Gallagher, who is a world-renowned gender-affirming surgeon based in Florida. I'm going to let Dr. Gallagher introduce herself and share briefly your experience, shares with viewers your experience, what type of gender-affirming surgeries you tend to perform, how many gender-affirming clients you have had, because we all know that number speaks volumes, right? That's how we know we really are talking to somebody who knows what they're doing. So please go ahead and introduce yourself.
Absolutely. Well, thank you very much for that introduction. So my name is Dr. Sidhbh Gallagher. Sidhbh is an old Irish name. That's why it's spelled very strangely. And I'm a plastic and reconstructive surgeon. I'm based here in Miami, Florida. I was a general surgeon before I was a plastic surgeon. And I've been doing gender affirmation surgery heavily for 10 years now. I absolutely love it. I have both clients who are assigned male at birth, assigned female at birth. I do a mix of top surgery, bottom surgery, and other body contouring, usually gender affirming type surgeries as well. I mean, to give you a number on how many I've treated, probably in the range of, I think, about 5,000 folks since I started practice, because it's been busy, because as many people know, that there's not many surgeons in this space and surgeons who specialize in this. So the upside of that for me is we're busy, but of course, many of our patients travel in. We've folks from all over the world to come to us for surgery here in Miami, Florida.
Wonderful. I also going to share, and I've shared this many times on my YouTube channel. I actually did a detailed discussion of your book, Affirmed, which is I find to be a phenomenal resource. If people are not familiar with this, grab your copy on Amazon, because you cover pretty much any gender affirming surgery in detail. You cover the different types of procedures. You also cover all the ins and outs that people need to know. And the best thing about this book is how incredibly accessible it is to the reader. It's not clouded and overcomplicated with medical language. It's very easy to digest. It's really reading for as a guide for particularly gender diverse individuals.
Yeah, well, thank you. So that was my pandemic baby. When we couldn't operate, I needed something to do. So I got together with 9 other specialists in the field. So it's not just my opinion on things. And that was our goal, to make it as accessible as possible, because really one of the unique things about gender affirming surgery is patients really need to be educated on the different options. Sometimes these are really complex, surgical procedures, but in order to know what's going to be the most affirming for the individual patient, they have to know what the options are. So we try to make it as simple as possible. Lots of pictures, lots of diagrams, big text, not too much text in there. But yeah, it's available on Amazon. You can get a hard copy, or you can get the Kindle version as well. And we give it to all our patients. It's very helpful as well. So
Yeah, it's a great book. So without further ado, I emailed notification that I will be having a privilege to sit down and talk to you today to all of my email subscribers, and I got a ton of questions, as you know, back. Now, because Dr. Gallagher is so specialized in a variety of gender affirming surgeries, and today we only have limited time, we decided to go ahead and focus on primarily on a ton of different vaginoplasty questions that we received, and then see if we can segment into breast augmentation. For anybody who's watching who is more maybe non-binary masc or transmasculine identified, we are hoping to find time to do separate segment just on those questions, because it's different type of surgeries and all of those warrant its own attention and time. So without further ado, we're going to jump right in, because the questions are really interesting and I am very eager to ask you about them. So the first question for today is, I heard vaginoplasty is the most complicated gender affirming surgery. And I hear this a lot. And that's what keeps a lot of my patients from actually scheduling even a consult to discuss with the doctor whether it is the most complicated. So I'd like to hear from you if that's true or not.
yeah. It is a big surgery. Is it the most complicated thing I do? Not necessarily. I would say probably for folks assigned female at birth, sometimes those procedures, depending on which we do, can be a little bit more complex. But it is a complicated surgery. It's a lot for a patient, especially a patient who's never had a surgery before. There is significant downtime. Things look really bad while they're healing. Things swell horrendously down there because if you think about it, if you operate on a hand, you can elevate a hand afterwards and help with the swelling. But I always tell our patients, there's no kind of way to really elevate down below, short of stand on your head,
Yeah.
obviously does that. So things will swell and will swell epically. Like it's not unusual to have that anatomy swell and distort up to like 4 times the size that it is. But then on top of that, especially if you have the vaginal canal created, now the onus is on you to dilate. So it's really the dilation, I would say, out of bottom surgery. That's probably the most onerous part or maybe complicated part, because our instinct as a patient when we have a freshly operated on site is to kind of put a band-aid on it and we want to forget about it. But some of the most complicated dilation you'll do, or definitely the most complicated dilation you'll do, is when things are still healing down below, and it's going to be so important. So that's when I always say we never want to underestimate this surgery, because you have to be prepared. You have to be at a good time in your life where you can take the right amount of time off work. And for a lot of patients, that's about 6 weeks. Not because you're bedridden for 6 weeks or you're in a terrible amount of pain, but you really have to commit to that early dilation, because in the early days, we're going to be dilating between 3 and 5 times a day typically. So it's kind of your full-time job as you learn how to do it and as you learn the anatomy. So that to me is kind of the most complicated part of vaginoplasty, in that there is a big role the patient plays, because of course, if you don't dilate, the new vaginal canal is going to always want to narrow down. We call that in medical talk, we call that stenosis, and it
Right.
is a common problem, and it can be difficult to treat it. We may need another surgery, to take care of it if the patient isn't in a place where they can dilate every day after surgery.
So we're looking at it from a point of view of complicated, as in it's going to take a lot of work, and it sounds like a lot of bulk work is on the patient, right?
Yeah.
If we were to modify this question in a sense of, out of all the gender affirming procedures, would you say that this is the surgery that has the highest potential risks?
So we have to mention there are some very serious risks with this surgery, that's for sure. Again, for folks assigned female at birth, doing things like urethral lengthening, that's probably more complicated. But in this, we're going to focus on folks assigned male at birth. And of course, the thing you have to know is there is one notorious complication that can happen when we're creating a vaginal canal, and that's fistula. Now, fistula is a very technical medical term, but it's thrown around. I'm going to explain exactly what that means, okay, and why it's so important for trans femme patients. So basically, when we're creating the new canal down there, if you think about it, there's very limited real estate. So we're going to create that canal where it belongs, just above where the rectum is, where you poop from, and where your urethra is, where you pee from. So we're going to create that new canal in there. Now, the problem is if we get an injury to the urethra, it usually heals pretty well. We do a few days with a catheter, it's usually not a big deal. However, if we get an injury to where you poop from or the rectum, that is a big deal, because the problem is the anus is high pressure and the stool coming down from above can preferentially leak out the new vagina. So we have what's called a neovaginal fistula, neo meaning new vagina fistula. And the reason that is such a problem is, in order to get that fistula healed up, we have to stop what's coming from above, i.e. the poop. And how are we going to do that? You got to eat. So what sometimes we have to do in that situation is to what we call divert the stool. So that means creating a bag. So putting a colostomy bag on the abdomen. And of course, a lot of my patients, beautiful young girls, busy in their lives, nobody's got time for an unexpected colostomy bag. So this is why this is one of the most kind of notorious complications. It's we quote about a rate of 1%, and the problem with that is it's going to take probably 2 more surgeries at least. We're going to reverse that colostomy bag usually at about 3 months, all things going well. And then what surgery are we going to do maybe to recreate that vaginal canal? Because usually things are very sealed up, obviously, because you're not dilating if you have this problem. So that's why that is one of the most notorious complications we have to discuss with patients, because obviously a lot of my patients, like I said, they don't have time for 2 or 3 extra surgeries. So that's why, it always comes up in every discussion about vaginoplasty. There are, of course, other complications, but usually they're a lot more minor than that one. Yeah.
So would it be fair to say that apart from 1% of population that tends to potentially experience fistula, other than that, this is seems to be pretty straightforward surgery, especially let me reverse it. Penile inversion specifically, because we are dealing with the same real estate. We're not doing urethral lengthening, right? We're doing urethral shortening. We're dealing with the same tissue. The surgery is penile inversion is what, approximately how long?
Yeah, so penile inversion surgery usually takes me between 4 and 5 hours typically. It's so confusing for patients because unfortunately us surgeons, we all like to do different things and different standards. Some surgeons will keep their patients in hospital like 2 weeks, even a month. I've heard in Southeast Asia, for example. However, in my practice, typically what we do is patient stays 2 to 3 days in hospital, depending on how her pain is after surgery. Usually I'll keep the catheter and the packing in for 1 week after surgery. We get rid of those. And then shortly after that, the patient can return home, because like I said, a lot of my patients travel in. So overall, if a patient is well educated, if she understands what she's getting into, in that she understands that 6 weeks, the dilation that's involved afterwards, if she has support in that, emotional support is extremely important after surgery as well. And she can take time off work, all that sort of thing, then yeah, it can be a very straightforward surgery. And I definitely have a lot of patients who just sailed through the whole process, and I'm in great admiration on all of them. But I would say probably the majority are in that category. But you gotta do it at the right time in your life. You gotta be prepared. Where we run into problems typically of folks who didn't fully think things through what they were signing up. They're under pressure to get back to work. They're running out of money. There's nobody around to support them emotionally, or even trips to the doctor, that sort of thing. That's where we typically run into problems.
Great. So this is what I wanted to clarify, because I get so many people that I work with that tell me they're terrified of vaginoplasty because of all of the complications and everything else. And while, like you pointed out, it is a complicated surgery, it does have that serious complication risk. I think it's also important to know that in today's world with social media, we tend to hear more about issues that have gone bad and people vocalize exams, and people who, like you said, sail through and then they move on in their life. So it's not that I'm trying to shepherd people into surgery, but I think it's good to have realistic expectations and to understand, yes, it's in the end of the day still surgery, but in terms of all gender affirming surgeries, it's not really necessarily like the most. I would say probably phalloplasty will be the top of the list.
Yeah.
So segmenting in the discussing vaginoplasties, the question that I have for you today is, do you have any recommendations on peritoneal pull-through or different types of vaginoplasty, specifically for someone who wants to retain as much sensation as possible and wants to be as close to cis person's vagina as possible? So this is just a loaded question. So let's explain to viewers what is peritoneal pull-through versus penile inversion. Let's talk about sensation. What are you experienced with that? And also discuss this idea of trying to get a body organ with this standard, right? The cis standard, and what are the reasonable expectations for that?
Absolutely, yeah. So that's really, the holy grail is trying to come up with a way to line that new vagina to make it as much as possible like a vagina found in somebody who's signed female at birth. So that's where we see the different types of vaginoplasty. And those different types of vaginoplasty are usually just different ways of trying to figure out how to line that new vagina. And so the peritoneal pull-through procedure has actually been around for a long time, but it got popularized again more recently. It was originally described by Davidoff, who did it for folks with vaginal agenesis. So 1 in 5,000 folks who have two X chromosomes are born without a vagina. So it was originally described in that. And so what they were trying to do was that rather than with a penile inversion vaginoplasty, where I'm using all the anatomy on the outside from down below, we're trying to line that vagina with something that's more like mucosa or more like the lining of a regular vagina. So the thought was we could use some of the peritoneum. Now, what is the peritoneum? So the peritoneum is the skin basically on the inside of your abdominal cavity. So just like you have skin on the outside, the inside of your abdominal cavity is lined with skin, and we can use some of that skin. We can drop it down what's called a flap. You won't notice it, but we can use that to line some of the new vagina. And the hope was that this may do certain things like make it more realistic, make it more resistant to narrowing stenosis like we talked about earlier. However, I'm not sure that we've really proven that that's the case. So a lot of us in the space, like myself, we offer both techniques. We educate our patients on what they're signing up for with either, I think either or is reasonable. But in medicine, whenever we're trying to make a claim, we always have to prove it with the science and the data. It takes a long time, to do that, but we can't just make claims that one's better than the other without showing that first. Where the peritoneal pull-through may do a little bit better is that it's lined mainly with mucosa, so it's not like skin. So when we have skin down there lining our new vagina, we have to clean it by douching. Now, douching, there's no mystery behind this term douching. It just basically means we're squirting soapy water up there as part of our, every time you take a shower, you just do it to clean the inside. It seems to be less important that you have to do that with the peritoneal pull-through. But other than that, does it decrease the need for dilation? No, doesn't seem to. Does it auto lubricate better? No, not necessarily. Is it more surgery? Yes. So I think I'm seeing a little bit of a trend away from pull through more recently in the past 2 years or so, because probably within the community, whenever you do more surgery, more things can go wrong, so there's probably more of those stories out there of folks who've had complications that you wouldn't have had if you were just doing the penile inversion. So with the peritoneal pull through, what's involved in that is I work from below, like I usually do, like a plastic surgeon, and usually a urologist goes in with a robot from the inside. They make 3 little incisions on the belly, and they go in there, and while I'm working on the outside, they're peeling down some of this peritoneal tissue to line the deeper part of the vagina and line as much of it as possible. So from the outside, both procedures look exactly the same. From a sensation perspective, which was in the question, both procedures should be exactly the same. The only difference is on the inside, what is actually lining that new vagina. And like I said, it's kind of, we show the patients all the evidence, and it comes down to a personal decision. The peritoneal, in my practice, I see there is a little bit more pain, which you'd expect because it's more surgery. It's 3 little incisions on the belly as well. So that's why we're seeing both procedures still widely used. And in my opinion, both are acceptable. And if anything, I'm seeing a trend back to penile inversion. And I think it's just because word has gotten out about, some folks who've had complications from the peritoneal pull through.
So the 1% of fistula you discussed, is that across the board regardless of what type of vaginoplasty?
It is. It seems to be. So I would say, one of the hopes is because we can see things both from the outside and the inside when we do the robotic procedure. But I don't think it makes a difference. I haven't seen, and nobody's published on that as far as I know yet. So we can't really claim that. So just knowing what I know, because I do both procedures, the risk is still there, with both. I would say it doesn't get rid of that risk. So.
And I'd like to touch base on the peritoneal being this mucous membrane that I assume secretes some form of substance, right? That's where I think there's a lot of misconceptions I hear that, the peritoneal vaginoplasty tends to self-lubricate. Can we touch base on this idea that the new vagina is going to self-lubricate, and how different is it from, for example, for somebody who is assigned female at birth, where you experience the sexual arousal, you produce that lubrication? Is that the same thing we're talking about here?
Yeah, well, I think most sexual health professionals will preach that lube is always going to be a girl's best friend. It doesn't matter, cis, trans, whatever. It's
Agree.
universally across the board. You know, it's one of your basic things in your toolkit in
100%.
general. So, having said that, there is some variation in how folks will auto lubricate after vaginoplasty. I haven't seen a significant difference, and just knowing what that kind of flimsy mucous membrane is like in the peritoneum, I really don't think it produces much fluid. I don't think it's a significant amount, to be honest. And so usually the thought is that if folks are self-lubricating, it's more coming from the urethra, because you still have plenty of urethra behind it. There are glands within the urethra, which are typically responsible for pre-ejaculate. So we know that anybody who has a penis, it varies how much pre-ejaculate they produce. It's anywhere from nothing to 5 cc's. And so a lot of that ability, even though we're doing urethral shortening, a lot of that ability will still persist. And the theory is we think that's probably more so what's responsible for auto lubrication in trans women, you know, after vaginoplasty. So I don't see a significant difference between the two procedures for that.
When we're talking about sensation, I hear a lot of trans women specifically talk about being able to achieve orgasm, in two ways. One is through clitoral stimulation. And I'd like for you to explain what exactly surgically happens to create a clitoris, right? And then also whether internal penetrative orgasms through penetrative intercourse is possible.
Yeah, yeah. So in modern day techniques, it's really like one of my main goals when I'm going in there is preserving sensation. And so we have what are called the pudendal nerves, which actually, interestingly, pudendal, apparently the root of that word is shame. I think in Latin, so your shame nerves should be preserved, and they go to the glands of the penis, or the head of the penis. And in most different techniques, there's lots of different techniques to make the clitoral anatomy, the chundri flap, various different ways. But in general, we're preserving some of that glands of the penis. We're going to decrease it greatly in size, but those nerves are still intact. And those nerves, they're quite tough nerves, thankfully, because we know this from, you know, kind of switching topics, folks who've had female genital mutilation oftentimes can still orgasm, you know, despite the fact that the end organ or the clitoris has been damaged. They seem to be quite tough nerves. Touch wood, I've never had a situation where we've knowingly cut these nerves. I've heard of other folks reporting it, and they do tend to heal pretty well. So completely losing sensation in the clitoris would be a very rare event. Now, having said that, the ability to orgasm can be slow to come back, you know, because one of the hallmarks of surgery, if you've never had a surgery, I would say it's just people feel the ick after surgery. They just feel gross, and it's not unusual with all the hormone changes and all the swelling down there, just kind of the stress of surgery. They just don't, you know, orgasm for like 3 months sometimes after surgery. I would say 3 months is pretty average, you know, for a lot of folks. And usually we say if you have the ability to orgasm before surgery, you should be able to orgasm after surgery. And technically, like you alluded to, we're maintaining those nerves, so we'll have the ability to orgasm from the clitoris, the new clitoris. But also, if you think about it, where the new vagina is positioned now, about like 2 inches inside, we have Miss Prostate is still there. And so for a lot of folks, prostate almost acts like a G spot, you know, similar. And some folks, you know, can definitely orgasm from prostatic stimulation alone. So that probably accounts for what's going on when folks, you know, get erogenous sensation from penetration. So, you know, and some lucky folks have both, some just have one. Some people do struggle, you know, after surgery. It can take a while for that orgasm to come back. But as a general rule with modern techniques, it's kind of low down on the risk of worries after surgery.
Ah, okay. Well, that's a positive. That's really good to know. When we're talking about the depths of the canal, and just to briefly outline for viewers, since we're focusing a lot on penile inversion and peritoneal pulsar, there are clearly also another surgery, two surgeries, right, that produce canal. That's non-penile inversion, that's popular more over abroad.
Yeah.
And then there is a sigmoid colon, which is it's more rare surgery in my understanding. That's when people had other complication risks or there's not enough tissue at all to create canal. That
Yeah.
becomes the opt-out surgery. But we're talking primarily about penile inversion and peritoneal surgery. So when we're talking about depths of canal, that's another thing that I hear a lot. People want something that has a lot of depths, which is another conversation altogether because the average size of, in the very least, if you're going to be having penetrative sex with somebody who has a penis, is not what a lot of people think it is. So what are your thoughts on canal? What is the average depth? What is that? What factors go into that in terms of being able to establish that?
Yeah, absolutely. So typically when I'm in there, regardless of what the patient tells me, pre-op, I'm going to try and make the deepest and the widest canal I safely can, simply because vaginal stenosis is very real. And so I want to make it as roomy as I can up front, just, to make dilation and, penetration, if that's in the patient's future, as easy as possible. Now, having said that, there's some limiting factors with the patient's anatomy. We may not get it as deep as we want, but typically, give or take, I'm usually aiming for about 6 inches, and usually that's kind of what we're getting, like a minimum of 6 inches. If we can do more, great. The average penis size in America is supposed to be about 5.5 inches. So, and I always say there's kind of a myth out there. I think that folks think that they need to accommodate something much bigger before they're able to have intercourse. And it seems to be that
Yes.
you really just have to shoot for what you're shooting for. So if you have a partner, for example, long-term partner, dilation wise, you don't have to go very much above and beyond their size, so in general. Now, some patients can upsize. It is possible to do that. I've certainly seen that in more ambitious patients. They'll go above and beyond. We always give patients a set of dilators, and in some patients they'll go beyond and buy bigger toys, that sort of thing, which is great. But in general, I would say most surgeons are probably on the same page as me. We're usually just trying to make the deepest, roomiest vagina we safely can, because that's the buzzword, like safely, because that's where, when we're creating that canal, there's limited real estate, like I mentioned, and we have to avoid those complications I mentioned before.
Right. So another question on this type of procedures is, what are the determining factors when deciding on PPT versus penile inversion? Again, PPT is peritoneal we're talking about, versus penile inversion techniques for vaginoplasty, and which form require complete hair removal and why?
Yeah, hair removal. Okay, so that's a good one. We didn't talk about that. So I'm a little bit controversial when it comes to hair removal. So, and I'll tell you what, it's just what I've experienced in my career. So many patients, when I started out my career in Indiana, they had been waiting 10, 20 years, to get bottom surgery. And so understandably, when they'd meet me, I'd say, well, you're going to have to go and do 6 months of hair removal down below. Some of them are in rural Indiana. Where are they going to go to get, somebody who can do laser hair removal down there, without getting stared at or whatever? So it's difficult. It's a significant hurdle, and it's also expensive, So there's electrolysis, there's laser hair removal. We never say it's removal, it's reduction. Both techniques are reduction. So what I was finding was ended up doing vaginoplasty on folks who swore pre-op, oh yeah, I've done all my laser hair removal. But in fact, they just kind of shaved down below, and then post-operatively they're like, yeah, maybe I didn't do it, so which I can understand, because they were just desperate to get their surgery. And so what we would do in those folks, like typically when we would turn over the graft we were going to use, and this is for penile inversion, we would see all the hair follicles on the backside of the graft. So what we would do is we'd have somebody in the operating room who would thin that graft out and go with cautery and specifically kind of do electrolysis basically in the operating room, but under a microscope, specifically looking at all those hair follicles. And that just kind of became a standard part of my procedure because I was seeing that in folks who had actually done, because it's always, like I said, it's hair reduction, not removal, so anybody who's had laser hair removal probably would agree with me. So none of these techniques are perfect. So we incorporated that into a technique that we're always we're doing our hair removal in the operating room. There's not many studies on this. There's one study out of Arizona, if I remember correctly, and they looked at folks, it was about 7% had problems with hair post-operatively, but in that study, it didn't matter if they'd done hair reduction techniques before and after surgery. So that's why in my practice, and I'm not the only one, there's some very reputable surgeons in Canada who have the same stance that I know of, and probably others. We said, well, we're not going to make it a barrier to getting surgery. So even with penile inversion. So with penile inversion, it would perhaps be more important than peritoneal, because the deepest part of that vagina is going to be lined with the peritoneum, which obviously, doesn't have hair. The concern is always that if we put hair-bearing skin in there, patients are going to develop problems later on. Now, I followed, when I took away that barrier, I followed the first 100 patients really carefully on that front, and none of them reported problems with hair afterwards. So that's why we took away that barrier. If you do have access to hair removal, absolutely great, but in my practice, it's not necessarily a barrier. And especially with the peritoneal technique, because like I said, the deepest part of that vagina. And in fact, with the urologist I use currently, Dr. Bianco is excellent. He can get that peritoneum way down. So the vast majority of that vagina is lined with peritoneum. So it's not as important at all.
So two questions. One is, if somebody how somebody even knows they have any hair post-surgery? Does it cause infection? Is it urinary tract infection? What are the signs to look out for?
Yeah. So the signs would be, and like I said, touch wood, I haven't seen it, so pain could be one sign, like a discharge if they're not able to clean up there properly, but urethral hair, you shouldn't get that, because urethra just comes like as a cis female. That will be more for folks who've had urethral lengthening, so different story and probably much more problematic. But like I said, that I know of, in my patient population, folks don't have that problem in general. So
if somebody hypothetically has a problem, how difficult is it to treat it?
So that is that is a great question, because like usually those techniques, it's now internal, so it could be possible to like I said, I've never been asked to treat it, but like surgically I could go in there if it's just a small area and remove that area. It's possible, like sometimes we have to do that post-operatively at the labiaplasty to remove scar tissue. So that's something I'm familiar with doing, if there's kind of tight scar tissue there, removing that. But yeah, touch wood, thankfully I haven't been asked to do that yet.
So to sum it up, in a contrast to penile inversion versus peritoneal, it seems like with peritoneal, there's still some hair removal required, but not as big of an area as it is for penile inversion, because again, most of the canal is lined with peritoneal tissue.
Yeah, absolutely. And so, so to compare one to the other, peritoneal, I would say a big thing that factors into people's choices, for better or worse, unfortunately, here in the United States, is going to be logistical things, So again, not many of us do the peritoneal. They don't even have that available to them, number one. Number two, certainly with me, our wait list is a lot longer for peritoneal. And I hate for folks to make lifelong decisions based on wait list, but it is significantly longer, because it takes me, the robot, and the urologist to be available as opposed to just me. So that is one thing. Cost as well. If folks are paying out of pocket, it can be a lot more expensive, with the extra surgeon and the robot. So those are logistical factors that go into it. More surgery, more potential for complications with the peritoneal. the penile inversion more kind of tried and tested. But with the peritoneal, again, the potential benefit that it's more vaginal-like lining, more mucinous lining. And then one group, which again we don't see, despite what you hear in the media, we may see later on, is potentially for folks who have been on puberty blockers. The peritoneal could be a lot more interesting for those patients because it doesn't rely on having tissue on the outside. So for folks who've been on puberty blockers and haven't had much development down below, that's where that could be very interesting for those patients.
Okay. So talking about, there's a great question here about dilation and maintaining depth. You already touched on stenosis being very, very common. Vaginal stenosis is when you don't dilate enough, so the canal starts shrinking and closing on, right? Which is one of the most common things that tends to happen. So the question is, with penile inversion specifically, are there any cases where the canal depth shrunk even with consistent daily dilation?
Yeah, so I would say there are a few things that can trip folks up, and I've had the most diligent patients who can still run into trouble. And I haven't seen a difference in my practice between peritoneal and penile inversion in both cases. And so typically we'll say there's three pretty common reasons why they may have issues with dilation. So number one would be a pelvic floor issue. So this is a lot like, cis women can get this too. Having a tight pelvic floor. And so they typically have problems from the get-go. Just difficulty passing that vagina through the muscles in the pelvic floor. And usually the way to treat this is going to be pelvic floor physical therapy. Like, it's an absolute game changer. And so pelvic floor physical therapists have a lot of expertise in these muscles and how to control them, how to control your breathing and slide that dilator past in order to maintain your depth. And, even if you're a patient, I've had many patients who traveled in for surgery and they were, let's say, in rural Wyoming, and they're like, where am I going to find a trans-affirmative pelvic floor specialist? I find anybody who is trained in pelvic floor physical therapy tend to know exactly what they're doing, because a pelvic floor is a pelvic floor. And most of us surgeons will make ourselves available if they have specific questions. But I find they are an amazing resource for folks who have pelvic floor issues, number one. Number two, I'd say the second most common reason is good old granulation tissue. Now, granulation tissue, you hear that term thrown around. What does it mean? So granulation tissue is basically a type of healing when your body kind of overshoots the runway. It kind of does a little bit too much. It's red, it's beefy, it's what we call friable, it bleeds a lot. And the thing is, it's painful. And so typically the typical areas it shows up is around the entrance of the vagina. And that can really mess up your dilation, because every time you put a dilator past it, it hurts and it can bleed. And so that's something, usually if it's going to happen, it happens within the first few months. It's usually, if it can recur, but typically at a year, it stops being bugging you. So usually your patient or your surgeon will treat that. There's an ointment you can put on it. You can actually put steroid creams on it as well. But I'm not going to say treat yourself at home. Talk to your surgeon about it. That's all part of the post-operative care. But that one is a very common one after surgery. And then the third one would be scar tissue. So sometimes this, the best surgery in the world, the most open vagina, the roomiest vagina, things, and the best patient in the world who's diligently dilating, sometimes just people form a lot of scar tissue. That tends to be a little bit later, kind of 3 months onwards is where we see that. And again, it causes pain with dilation. You can kind of feel the scar tissue around the entrance of the canal usually. But again, that's a question for your surgeon. And typically it's something, in most patients, I always tell patients with vaginoplasty, certainly the way I do it, we want to always plan for 2 procedures. We try to do everything at the first surgery, but there's certain maneuvers we need the second surgery to do the labiaplasty. And typically at the labiaplasty, we can fix that scar tissue problem.
Okay, so it sounds like depth canal can shrink and close, even though you're doing your best diligence with dilation, regardless of type of surgical procedure. If that does happen, I do know for penile inversion, then people do have an option of, like, maybe even peritoneal, or maybe they have an option of sigmoid colon to create canal. For people who had peritoneal pull-through and it happens to, what are their options?
So typically what I do, the first thing, and we'll schedule a labiaplasty and an exam under anesthetic. So usually I'll try and like see the patient if at all possible, because sometimes it's a dilation problem, and maybe, if we don't wait too long, we can get in there and salvage things from the get-go. So that's preference number one. In my practice, it's not always possible, because folks travel in, or just sometimes there's a lot of shame around these things sometimes. And, the patient will come to me tearful and say, oh, I haven't dilated in 3 months. And that's okay. We're never going to scold you, So, at that point, we're probably going to need to do another surgery. And usually my first thing to do is do the labiaplasty, because we're going to have to do that anyway, and do an exam and dilation under anesthetic. So typically what I'll do is, and touch wood, like I think I have a pretty good success rate. I'm not going to say it's 100%, but it's pretty high of kind of sneaking back in there and opening up, with the understanding that one, it's more dangerous, because things are scarred and we're at a higher risk of injuring that rectum and getting a fistula. And two, that this time the patient is ready to dilate. And, if that was the issue in the first place, we've addressed things like the scar tissue and all that. So we're going to be much more successful this time. So basically what I do in that situation is just very carefully go in there and find it. I had one recently, a Peritoneal, and, she had a lot of scar tissue at the opening, but then once we got past that, thankfully the canal was intact. And in some cases, I'll pack that vagina again, like before, to let everything sit and open up, and just get the patient back dilating again. So, that's not always the case. It's a riskier surgery. So, prevention is always better than the cure, if at all possible.
Okay, so because I know time is a factor, and I want to wrap up on a question to give everybody kind of a, something to consider if they're thinking about peritoneal, vaginoplasty, and penile inversion, and choosing between the two. Can you describe between each one of them, which is a single, and maybe there's one for both the same, what single factor have you seen consistently contributing to poor recovery with penile inversion and peritoneal?
Yeah, I would say both of them. I'm going to say here, it's emotional issues after surgery. It's a girl who, or a patient who, like, that's usually who has a lot of anxiety, who maybe wasn't educated that much beforehand, because this surgery, it's, and, you and I have talked about this before. It is an emotional roller coaster, and there's so many reasons for that, right? There's hormonal reasons being taken out of your usual routine. So I would say the single most important factor, because we always correct the medical things, right? If somebody's diabetic, we're not going to go ahead with surgery, but the emotional thing can be a little bit harder, to nail down, because we don't have any blood tests for that. So I would say the single most important thing is just being in a good space emotionally before surgery, because where we trip up is folks who have very high anxiety, who maybe don't reach out, when they stop dilating, they don't reach out for help, because their anxiety is getting at them, or they just, stop dilating altogether, because they're just not in a space they can do it. So that's typically where we see bad outcomes, just people make bad decisions. I had a patient who had a drug habit, who, again, she was, the stress of surgery, she had a relapse, and obviously that didn't go well, either. So I would say that to me is the single most important thing, because we're able to screen for the other things, right? The blood pressure, the diabetes, we blood tests, we have numbers, we know when we're good to go, but that is harder to nail down.
That's a great wrap up for everybody who wants any kind of gender affirming surgery, to make sure that psychologically you are educated, you have support system, you have realistic expectations, which I would say is really, really important. And you have coping things set up post-surgery in case if you do get stressed. Post-surgical depression is absolutely a real thing, in order to handle all of those things. Well, having said that, I'm so grateful. Thank you so, so much. This is such an honor to sit down with you. I'm sure that many viewers will find this invaluable, especially how we've been contrasting both of the procedures. I know people are still trying to decide which one is best for them. And I know that this video is going to help so many make a better decision. Thank you so much.
All right. Thank you for having me.